this video will focus on the evolution of ischemic strokes, also known as infarcts. As a stroke evolves over time, its appearance on imaging will change. This timeline can be broken down into 4 phases. The hyperacute phase lasts for under 1 day. The acute phase covers days 1 to 7 after a stroke. The subacute phase covers weeks 1 to 3 after, while the chronic phase covers everything from 3 weeks outwards. In evaluating a stroke, one of the first studies obtained will be the non-contrast CT. This is primarily to rule out a hemorrhagic stroke. In the hyperacute phase of an ischemic stroke, the non-contrast CT is most often normal, as in image 1. An acute hemorrhagic stroke, in contrast, will be visibly abnormal, as seen in image 2. That said, there are some signs of an acute infarct that can sometimes be seen in the hyperacute phase. One such sign is the dense vessel sign. The thrombosed area of the vessel will typically be hyperattenuating due to the clot having greater density than non-clotted blood, as demonstrated in the right MCA in image 3. This correlates with image 4, where CT angiography demonstrates a filling defect that corresponds to the thrombus in image 3. Though the dense vessel sign is not often seen, when present it can help identify patients who are likely to have an occluded vessel. Around 12 to 24 hours after onset of symptoms, as the infarct enters the acute phase, edema develops as damage to the surrounding brain tissue progresses. The infarct thus becomes visible on non-contrast CT as an area of hypoattenuation and loss of gray-white differentiation. The developing edema often results in mass effects, such as gyral enlargement and crowding of nearby cerebrospinal fluid spaces, such as the ventricles and sulci. These signs are apparent in image 5, which has extensive hypoattenuation in the territory of the left MCA, as well as signs of mass effect in the narrowed left lateral ventricle and sulcal effacement. Image 6 provides an example of hypoattenuation without any apparent mass effect. The right insula is notably darker than the left insula and no longer has the bands of alternating brightness normally present. Of note, smaller infarcts may never become apparent on CT. During the subacute phase, swelling begins to decrease, and the affected cortex may temporarily approach normal brain tissue attenuation on CT. This is known as the fogging effect, and is illustrated in the 3 images here. Image 7 is of an acute infarct and demonstrates hypoattenuation in the posterior left MCA vascular territory. In image 8, taken a few weeks later during the subacute phase, the area of hypoattenuation is no longer clearly present. By image 9, taken a year later, the area of hypoattenuation is once again visible. As progressive tissue breakdown occurs, the affected brain parenchyma will become increasingly more hypoattenuating, sometimes approaching the attenuation of cerebrospinal fluid. This tissue loss is known as encephalomalacia, and the loss of brain volume results in the enlargement of ventricles and sulci near the affected area. This ventricular enlargement is known as ex vacuo enlargement. These chronic changes are demonstrated in image 10. Where this patient has a chronic left MCA territory infarct, the involved area is both hypoattenuating and has associated volume loss, with notable enlargement of the left ventricle. Once an infarct is identified, CT angiography is done to identify the arterial occlusion responsible for the infarct. Iodinated contrast is injected intravenously, usually in the arm, and the study then timed so that the head and neck are imaged when the contrast is passing through the arteries of interest. The contrast will appear bright in arteries with normal blood flow and dark in arteries without normal blood flow due to the lack of contrast. This is illustrated in this image here, which you may recognize from our dense vessel sign slide. Notice the abrupt transition from bright to dark in the right MCA. All visualized arteries are bright, save for the area affected by the thrombus. Once the culprit has been identified, it can then be assessed to determine whether an intervention can be performed to hopefully reverse or prevent progression of the stroke's symptoms. CT perfusion imaging can determine how much brain tissue is at risk but still salvageable, and thus whether a patient will benefit from intervention. To acquire a CT perfusion scan, the patient is injected with IV iodinated contrast and the brain is imaged repeatedly as the contrast bolus passes through the intracranial arteries, capillary beds and tissues, and veins. This allows us to determine which areas of the brain are not getting enough blood or are being perfused too slowly. Many kinds of perfusion maps can be calculated, but we will focus on two for simplicity: the relative cerebral blood flow, aka CBF or RCBF, and timed maximum, aka Tmax. CBF shows the relative amount of blood that is going to each part of the brain, while Tmax is a marker of how quickly blood gets there. If the CBF falls below a certain threshold in an area of the brain, then that area is likely not getting enough blood flow to stay alive. If Tmax is increased, blood is taking longer than expected to arrive at the area of the brain, and that area is considered at risk for dying. Comparing these two maps will help us determine the size of the penumbra, which is the brain tissue that is at risk for dying but is still salvageable. This example is from a patient with a right MCA occlusion. The CBF map shows a small area of decreased perfusion in the right basal ganglia, though it otherwise looks symmetrical. However, the Tmax map shows a very large area of symmetric elevation in the right MCA vascular territory. This suggests that only a small area is receiving reduced blood, while a large area of the brain is receiving blood more slowly than usual. This patient likely only has a small infarct and a large penumbra, and they would be a very good candidate for thrombectomy. The second example is also of a patient with a right MCA occlusion. Here, however, the CBF and Tmax maps both show matching large areas of abnormality in the right MCA vascular territory. This means that there is a large infarct with minimal, if any, surrounding penumbra. As there is little salvageable tissue, this patient would not be a good candidate for thrombectomy. CT perfusion can thus play a role in the decision-making process for determining which patients will benefit from a neurointervention. MRI is far more sensitive than CT at detecting acute ischemic strokes, and of its different modalities, diffusion-weighted imaging is the most important sequence for these purposes. Almost immediately after an infarct, the DWI sequence will show abnormally hyperintense signals, while its corresponding ADC map will show abnormally hypointense signals. This combination indicates that there is restricted diffusion, and the area of abnormality will correspond to the infarct. That said, though restricted diffusion is most often associated with acute infarcts, it can also be seen with tumors, abscesses, and other pathologies, so keep in mind the patient's history. An infarct will remain hyperintense on DWI for up to 10 to 14 days, and usually normalizes on the ADC sequence by 7 to 10 days. Chronic infarcts appear hyperintense on ADC and are variable on DWI. So let's run through an example case. Let's say we have an 80-year-old female with a history of coronary artery disease, hypertension, and type 2 diabetes who has had no recent illnesses. She is presenting with aphasia and right-sided weakness. Her last known normal was 4 hours ago. As far as our first step goes, that would be to get a non-contrast CT. The non-contrast CT shows no signs of an acute hemorrhage and no early signs of an acute infarct. As there is suspicion that she may have an acute infarct, a CTA is done. The CTA shows occlusion of the proximal left MCA. To determine whether she would benefit from an intervention, CT perfusion is performed. The CBF map looks symmetric from side to side, but the Tmax map shows a large area of elevated signal in the left MCA vascular territory. This suggests that there is a potentially large penumbra, and that there is probably not a large infarct at this moment, indicating that intervention would likely be beneficial. Our patient is taken to the angiography suite, and our neurointerventionalist finds the left MCA occlusion, which is shown in the image to the left. A small catheter is used to suction out the clot. After the clot is removed, imaging shows that the MCA and its branches are now filling in normally, as we can see in this image on the right. After this, her symptoms slowly begin to improve. After being stabilized in the ICU, the next day our patient is taken for an MRI. DWI shows a few small areas of hyperintense signal in the left basal ganglia and inferior left frontal lobe, with corresponding hypointense signal on the ADC map. and these indicate that there are a few small acute infarcts. Fortunately, this also suggests that nearly all of the MCA territory was saved. In summary, non-contrast CTs help to rule out hemorrhage and to look for early signs of an infarct, though they will often be normal in the hyperacute phase. Edema causes hypoattenuation and mass effect in acute infarcts, while subacute infarcts may temporarily appear invisible. Chronic infarcts will show hypoattenuation, and brain volume loss results in expansion of sulcal and ventricular spaces. CT angiography helps to find occluded arteries that can be potentially treated by a neurointerventionalist. CT perfusion is helpful for determining how much penumbra is present and can play a role in deciding which patients would benefit from a thrombectomy. And lastly, MRI, especially with DWI and ADC, is the most sensitive for an acute infarct.